Let me put it this way, Trevor.
Institutional memory.
Let me put it this way.
Yes.
There is no public or private patient. Yeah? So Mwananchi is saying that when they go to the health facility, there is no doctor, the health facility is far, there are no drugs, they have increased waiting time, and they cannot afford. Yeah? So we need to solve this problem. The correct model of healthcare devolution and delivery was curative health at a national level. You have the medical equipment scheme for equipment and the Health Service Commission for human resources. At the county level, they were supposed to deal with public and promotive health, because once you prevent an illness like cholera, for instance, for every one cholera prevented, you have saved, for every one shilling spent on public health care, 16 shillings is saved on curative health care. So they are supposed to deal with social determinants of health. Housing, if you have good housing, in fact, I'm surprised now, housing should be dealt with at a county level, not national level. Yeah. Water and sewerage, that prevents diseases. Nutrition. So after, then maybe something that we haven't touched on, and maybe you'll need to call another program for that, is that Kenya has never costed healthcare. How much does it cost to serve Mwananchi at the government facility? That's where we start. Private facilities have costed. Talk to Dr. Abdi Mohamed of Ladnan, Gakombe, Team Theory of KHF. They'll show you how to cost, but you will then know how much you need to run the health facilities at each end. An attempt was made in 2013. I don't know whether Nyekal remembers that, but this report was sent and it was shelved. It was the end of the report, because it probably said that this money, you need to give it to the county for you to deliver that service code. So we need to cost individual level, family level, and a population level. Then we can channel the money to what we are going to now, primary healthcare, PHC. And we need to shift now our focus to physician-led primary healthcare, PHC. This, you have a hub and spoke model, and at the base you have community health workers. They have changed the name a bit to promoters. I might need to know what that is. So when you have that base, you have PHC at the community level, and then you have the hub and spoke, which is a physician-led, and then you have all these feeding into that. And when you promote PHC, then UHC is achieved. You prevent diseases, but you have also strengthened the curative model. So, but let's cost healthcare.
This physician-led issue that you're talking about, the PHC, we also have to talk about some unethical conduct of the same physicians you're talking about. And this is an accusation that has always come up. Yeah. That sometimes you then refer people to other places, there's misdiagnosis here and there. How then can that be addressed?
So again, you've mixed, like the press normally do, many issues. Yeah. So if you are dealing with an unethical practice, deal with it that. Normally what happens is people throw the baby with the bath water. So you say, if for instance, we say a cabinet secretary was involved in some corruption, then we make a statement like all cabinet secretaries are corrupt. You see, so that blurs the picture. So let's deal with individuals as individuals. If someone, and again, part of the problem with health is that the autonomy has been taken away from the people who are supposed to be running healthcare. And this was an argument I had with one of the governors, who, when I told him, by the way, a health service commission will help devolution, he told me, if I can't control my workers, then I do not have power over them. So what happens? The health workers, of course, they cannot control. But if you allow them to do like we had in 2007 to 2013, where each individual unit is accountable, it becomes easier. So let's not throw the baby with bathwater by throwing in, that confuses things. A physician-led primary healthcare model. You see, there has been this concept that, oh, no, doctors cannot work in the community. No. In fact, they're the right people to work in the community. They've been seeing, like, I'm an obstetrician gynecologist. I ran a clinic yesterday at a county hospital. And the problems I am seeing, I have already identified the problem at community level. So I should be the one to generate policies and also guide. I should now also be going to the community to say, you cannot be having cancer of the cervix at this stage. Why? They went to the community. No one has ever gone to tell them you need screening and all. You see, so that concept of health needs, you don't dichotomize everything. It's neither here. It's just the way they are trying to say there is curative health and preventive health. No, it's a continuum. One feeds into the other and the other feeds, which was the same thing like what they said in Schedule 4, a referral health facility. Referral health facilities were from dispensary till level 5. There was referring and reverse referral. So when you now start saying referral health facilities is Kejata, Mathare, you have killed the previous concept, which was in National Health Sector Strategic Plan 2 of 2007 to 2010. So for your benefit, so that you say, oh, health is devolved. It's not devolved. It's a shared function with misinterpretation of
okay, Davji.